Okay, so let's talk about soft tissue. What?
There should be a button like a yellow button. Yeah, that one. Minimize it.
Okay. Okay, so talk about soft tissue tumors. Now, the WHO classification for soft tissue tumors includes lipid tumors, fibroblastic, fibrohistiocytic. Under the lipid tumors are lipoma and liposarcomas, fibroblastic, nodular fasciitis, and fibrosarcomas. Fibrocystic or giant cell tumors of tendon sheath and pleomorphic sarcomas, smooth muscle, myoma, and leiomyosarcomas, parasitic such as glomus tumors, skeletal muscle, rhabdomyosarcomas, vascular hemangiomas, and chondroosseous soft tissue chondromas, and then uncertain etiology are the myxomas and synovial sarcomas. And then there's some non-classified tumors that I'd also like to include in this talk, including Morton's neuroma, neurofibroma, schwannoma, PNSTs, non-neoplastics, and hematogenous lymphoid tumors in the soft tissues. So first thing is, how do you characterize tumors or masses in the soft tissues? And this is a nice article by Wu et al. In Radiology in 2009. Where they classified masses based upon their T1 signal, the T2 signal, and there were the T1 hyperintense, the T2 hypointense, and T2 hyperintense. So if you have T1 hyperintense, you're typically talking about tumors that have fat in them, hematoma, ganglion cysts and abscesses that have high protein content, and melanomas. T2 hypointense are lesions that have scar, like fibromas, giant cell tumors of tendon sheath with hemosiderin deposition in them, and lymphoma. If you have calcium in them, like gout or other calcified lesions, and then hemosiderin, like giant cell tumor of tendon sheath. And then you have the T2 hyperintense lesions, which have a lot of free water in them, which are cysts, or solid lesions that have a lot of free water within the cells, such as myxoid lesions, peripheral neural lesions, and synovial sarcomas. Now, if you see a lesion that's high in signal intensity on T1 weighted image, the first thing you really should do is do a fat suppress sequence to see whether the high signal intensity is due to lipid or not. If there is no fat suppression, then you're talking about a lesion that's containing methemoglobin, typically more in the brain. This tends to not to be a common phenomenon in the peripheral musculoskeletal system, but occasionally we can see high signal intensity from methemoglobin. Whether it's proteinaceous tissue, like a fluid, like a ganglion cyst or abscess, and then a melanin-containing lesion. If there is fat suppression, then you're talking about lipoma, and then you should check to see if there are calcifications, either on the MR, or it's nice to get an X-ray to evaluate that, or in some cases a CT. If there are no calcifications, then you're really talking about lipomas, their variants, well-differentiated liposarcoma, hemangiomas, and other fat-containing lesions. If there are calcifications, then if it looks like a phlebolith, then you're talking about hemangioma. It can be very helpful in that diagnosis, and we'll see a bunch of those cases. And Myositis Ossificans tends to have more of a peripheral calcification pattern. Now, if you're hypointense on T2 weighted images, you need to check to see if there's calcifications. If you are, you're really talking about a calcified mass, which limits the diagnosis. If there are no calcifications, then you're talking about a lesion that's either a fibrous lesion or hemosiderin lesions, and then you can location can be helpful. Plantar fibroma, giant cell tumors, tendon sheath, elastofibromas, and post-op scar all have characteristic locations, especially if they've had surgery. Ones that are kind of non-specific in areas that wouldn't be typical of these would be the other lesions, such as fibroma, desmoid tumors, leiomyosarcomas, fibrosarcomas, and that category. So this can be a little bit helpful. And if And then the hemosiderin containing lesions are typically giant cell tumor, PBNS, and hemorrhagic masses. If you have hyperintense on T2 weighted image, I'd like to look at the pattern. If it's just a rim pattern, so that you have a nice sharp rim around it, then you're really dealing with focal fluid collection. If it's a more complex high signal intensity on the T2 weighted images, then you can be thinking in terms of myxoma, which are malignant lesions, or synovial sarcoma, peripheral neurotumors, and a necrotic tumor with necrosis in the center. And we'll see examples of all of these. Now, other criteria that people have found to be somewhat useful from a statistical basis for differentiating malignant from benign lesions on MRI include the size, where typically greater than 5 centimeters is more associated with malignant disease than benign disease. You look for surrounding edema. This is the one I find a little bit less helpful. If there's a lot of edema, then you're typically dealing with an inflammatory condition and not a malignant condition. But benign lesions tend not to have any edema around them. Some malignant lesions can have some edema around them, but I personally have not found this to be very useful, but it is in the literature. If you have very inhomogeneous signal intensity, that tends to be a more complex lesion, which tends to be more of a malignant type lesion. If you do MRI perfusion studies, where you look at enhancement within 1 minute of injection of the contrast, early injection tends to be associated with acute inflammatory disease and or malignant disease, whereas benign disease, if it enhances, tends to enhance later than the 1 minute phase. If you see central liquefaction, where you get a complex fluid with very irregular margins, that's associated with central necrosis, which tends to be in malignant lesions that are aggressive and rapidly growing and outgrow their blood supply. And then if you see the lesion actually going through soft tissue fascia, especially the deep fascia of the skin, that's a good sign that it's malignant, because most benign lesions will not go through a fascial plane. Even infection tends not to go through a fascial plane. Now, if you look at superficial soft tissue sarcomas, they're fairly uncommon lesions to begin with. But if you see them, this is a nice article from Morel, which kind of breaks them down into the different types of superficial and subcutaneous lesions. And again, they found that the single best way to differentiate malignant from non-malignant is if they violated the deep fascial plane at the base of the skin. And this just shows what they are: liposarcomas, malignant fibrohistiocytomas tend to be common, and the unclassified. So let's start talking now about different lesions. And I'd like to start the first one with tumor-like. As you know, the word tumor just means a space-occupying lesion. So anything that occupies space that's not normally there is a tumor. It doesn't mean whether it's malignant or benign, but we can start with lesions that tend not to be classified as tumors in the WHO classification or other classifications, but they are actual mass lesions that we see commonly. So it's important. One is a ganglion cyst. These tend to be fluid collections from joints or tendon sheaths that expand an area of weakness in the capsule and present as soft tissue masses. One of the most common is a dorsal ganglion cyst that you see here on the wrist. You've all seen these. They're commonly imaged by MR, though the diagnosis is easy to make clinically, and MR doesn't really change the management or anything else on these. But this is a typical dorsal ganglion cyst, and you've all seen a lot of cysts associated with joint spaces and with tendon sheaths, and we'll see a lot more as we go forward. Another common area where you can get a mass is in the intermetatarsal bursa with intrametatarsal bursitis, which we can see here, And there you can see the fluid in between the two there also. 49-year-old female with hip pain. And this is another very characteristic location where we have fluid from the joint space going into the iliopsoas bursa. In this particular case, there's also a loose body within the iliopsoas bursa. So iliopsoas bursitis is another fairly common location of a mass, something that presents as a mass, which is really a benign lesion. And another one is the infra-patellar bursa here, where we can see an abnormal amount of fluid. As we've gone through before, you normally see a little bit of fluid always down here, but when it's more than just a sliver, it's abnormal. It can also present with a mass in this particular location. So that's infra-patellar bursitis. And you've all seen many of these. Now the ganglion cysts at the periphery of the capsule of the knee joint up near the insertion of the gastrocnemius, typically multiseptated as we're seeing here. Another just common benign lesion. 52-year-old male with abrupt left hip contracture, a lot of complex echogenicity. Here's the mass on the MR examination where we can see this. These are T1 weighted image. We can see a lot of high signal intensity within the lesion. On the T2 weighted image, we see areas of low signal, but also some fluid collection within this particular lesion. There you can see it on the coronal images within the pelvis, and this turned out to be an intramuscular hemorrhage. The patient was on Coumadin. So, and again, this one, when we go back and characterize that using what we've talked about before, there are bright areas on a T1 weighted image, so we have to think in terms of something that would be a liposarcoma or hematoma. Those are really the two where this would be methemoglobin. Or the other thing that you always have to think about when you see a lesion like this is melanoma. And I'll show examples of melanoma like this later as well. This one is much more complex when we get into the other sequences, which then takes it out really of the liposarcoma stage, though I guess it still could be, but it starts looking much more like a complex hematoma when we see the low signal intensity and areas of fluid containing in it, almost like a fluid level on the T2 weighted images. Okay, so that's hemorrhage. Another lesion along these same lines. Here we can see a fluid level here, and this is a prepatellar bursitis, which, as we talked about before, I think in most cases is subcutaneous venous hemorrhage from trauma overlying it. And here we can just see the fluid level from the hematoma produced. And these are due to trauma in this particular case. You could also put this as a Morel-Lavallee lesion, which is basically a glancing blow, which is a shear injury to the skin, which produces venous hemorrhage, and you get a hematoma in that location. So, okay, here's another soft tissue lesion around the joints, where we can see a lot of inhomogeneous, but in large part low signal intensity mass around the shoulder joint here, all the way around in areas of the synovium, extending and expanding the joint space. Here we can see all this lesion. It's really also involving the rotator cuff. And this is amyloidosis. We'll see other examples of amyloidosis as well. The history here is almost always chronic renal failure, typically with diabetes. You tend to get symmetric involvement. You tend to get these large dark masses around the large joints. It's very typical around the hips. We'll see some of this around the hips as well as around the shoulders. And then with this, you tend to get a lot of accelerated degenerative disease of those joints as well. And they get a lot of fibrotic changes. Another lesion here that we can characterize, here's the primarily fairly low signal intensity on either side of the bone up around the DIP. On the axial images, we can see this large area of low signal intensity on the T2 weighted image. Here we can see these nodular areas of abnormal signal. Then it would be good to get an X-ray on this to see if it's calcified. A lot of these kind of lesions will be calcified, but it looks like probably a fibrous lesion which may or may not be calcified, and this is dermatomyositis. It's a chronic lesion, inflammation that then leads to scar formation and fibrous deposition in the lesions. Here we can see. Yes. Go ahead.
Would Would you be able to tell that apart from a tendon sheath giant cell tumor since they're both dark on T2?
Generally, you can. And when we get to the hand, I'll actually show a longer differential of this and different lesions specific to the hand. Typical giant cell tumors of tendon sheath will be along the tendon sheath itself. This is more into the subcutaneous tissues rather than along the anatomic alignment along the tendon sheath. So I wouldn't really expect giant cell tumor in this peripheral location. And then typically these will be calcified, whereas giant cell tumors of tendon sheath can, but not as commonly. Here's another lesion of low signal intensity on the gradient echo T1 weighted images, also mostly low signal intensity on the STIR images on this low field scanner. See it marked around. It's typically fibrosis or a calcium deposition in these lesions to be this low. And this was actually scleroderma. So when we see lesions that have low signal intensity on T2 weighted images, especially in the skin, most of them are going to be benign. You can have malignant fibrous lesions which are low in signal intensity, but most malignant lesions have cells that are full of water, are actively dividing, much more aggressive, destroy everything around them, and are not low in signal intensity on the T2 weighted images. So most lesions which are low on signal on a T2 weighted images are going to be more in the benign or very low aggressive categories. But what you need to think of in the differential are hematoma, PVNS, as was mentioned, fibromas, sclerosing perineuromas, scleroderma, and dermatomyositis, the typical ones. You can also put foreign body into that, but they're usually pretty characteristic, and we'll see a bunch of those as we go forward too. Okay, so those are kind of the tumor, a few of the tumor-like lesions that I just wanted to make sure that we went over. Now let's talk a little bit about lipid lesions. And again, we'll see a lot more of these. I just want to do an overview of what these lesions look like, and then we will look at a large number of them in different locations within the body when we get into the different masses in the different body parts. So here we can see very typical appearing lesions. This looks like it's within the muscle with muscle surrounding it, very sharp margins. And on all T1 weighted image, it's very uniformly high in signal intensity. And if we do fat suppression, this is an old study, on a STIR image we can see that there's nice uniform fat suppression. This is a benign lipoma. And in the early days when we were doing this back in the 1980s, we're always concerned about whether you could actually exclude how good MR was to determine whether it is malignant or not. And a lot of people who have these lipomas can have literally hundreds on their body. It's really pretty common. And very early on, we realized that there are some major advantages of MR in looking at these. One is we can really see the entire lesion with MR. We can also determine whether there's fat suppression through the entire lesion. And you don't get sampling errors with MR because of that. And it's turned out that MR has been very reliable at determining whether or not these are, when they have benign characteristics, it's you can confidently state that it's a benign lipoma. So this is a lipoma. Let me see. I don't know if I have a slide here in a minute, but we will later. What you look for to see it's benign, benign lipomas can have septa in them, especially as we'll see on some examples. If it grows around a neurovascular bundle, it can come back and grow back to itself, and you can see the neurovascular bundle in the middle, and you'll get a thin septa where the two capsules of the lipoma coalesce with one another. But those septa should never be more than 2 millimeters in thickness. And they should be nice and smooth with uniform thickness. You should not have any nodularity to it. So if you see septa that are greater than 2 millimeters in thickness, and especially if they're nodular, then you can no longer categorize it in the benign category. And you have to be concerned about it. It doesn't mean it's malignant, but it means you can't ascribe it to being completely benign. Also, you should have complete fat suppression in a benign lesion. Now, there are a number of benign lipomas, especially brown fat lipomas, that will have a lot of increased signal intensity within them when you do fat suppression. Most of those are going to be benign, but you still can't put them in the definitely benign category, and they're relatively uncommon. But we'll see examples of those as well. Liposarcomas have a fairly characteristic appearance. and medium grade to high grade liposarcomas, you don't see fat in them like this. The fat that's in them is microscopic and not something that you'll see filling a voxel in an MR or a CT scan. But we'll get more examples of this. Here's a 36-year-old male, palpable mass lesion on the left thigh for a year, pain for 2 months. And here we can see, here's a fat lesion, very sharp margins, but notice on the fat suppressed images there's a lot of increased signal intensity within it, and some increase and some loss of signal down here. Now most of these lesions are still going to be benign, but a lesion like this you can't just categorize into the benign category. You have to be worried about it. And here are just some more examples. Enhancement, there's a little more uniform enhancement. In a typically benign lipoma, you will not see enhancement. But this was excised, and it was a benign lipoma throughout the lesion. So when you see complex lipid lesions like this, again, most of them are going to be benign, but you can't categorize it as benign. And you've got to tell the clinician you have to include a low-grade liposarcoma in the differential diagnosis. And it has to be either followed closely or excised. Now here's chronic wrist pain. Here's someone where we can see a little bit of lipid in this lesion, but this is really a massively enlarged median nerve. And follow it down into the area of the carpal tunnel. If we go into the muscles that are innervated by this, we can see there's marked fatty atrophy, well actually fatty hypertrophy in this particular case, due to the chronic denervation, and this is a fibrolipoma of the nerve. These, by far the most common location for this is in the carpal tunnel, I think, but you can also see it involve the peroneal nerve around the knee and rarely in other locations. But wherever you see these, there's a very typical pattern. They're at areas where there's some sort of a anatomic reason why there's chronic trauma to the nerve in those locations. And I think these are similar to the kind of lesions that you'll see with Morton's neuroma. I think these are due to chronic repetitive trauma to the nerve. However, these are often categorized as congenital lesions, but I am not aware at this point, and I've never really seen them in young kids. So I really think that often this is a nerve reaction to chronic trauma. Here we can see a 40-year-old female, mass in the right inguinal area on the plain film. MR examination, again we can see a lipid mass. Again we have a lot of the septa in them. With not complete fat suppression, so this would be another one of those in intermediate category. Certainly this increased signal intensity in this region would be very worrisome, so you couldn't put this in a straight benign category. This is what it looked like when it was removed. The pathology was looked at carefully throughout, and this was a hibernoma or brown fat lesion, and they tend to have this kind of a more worrisome pattern. But again, most of the lesions that have a lot of lipid in them, even if they have all these other characteristics, they're going to be benign, but not all of them. Some of them are going to have sarcomatous change within them, and therefore you have to treat them with respect. Another lesion, here we can see thickening and irregularity, frond-like pattern to the synovium in the knee. If you look carefully, you can see a lot of streaks of fat within these, so this is another lesion that has fat in it, which we have here, and you're all familiar with this, Lipoma Arborescens. And this is probably chronic inflammatory disease where you get some fatty laying down in the areas of chronic. Acute inflammatory lesions, you're not going to see fat in them, but when they get chronic and fibrotic, you can see fat deposition into them. 52-year-old male, we can see these verrucous plaques on the skin here. Recent increase in size, so this is an MR scan where you can see this fatty tumor with all this fibrous tissue within it, and it's very irregular on the surface. Other examples, and we can see some inhomogeneous signal intensity within these, but mostly a fatty type lesion. And this is Nevus lipomatosis superficialis. Again, another benign lesion in the dermis, but often primarily containing fat. And then here's another lesion that looks low in density on a CT scan. Here on the MR, it looks like it's bright on the T1 weighted image, but it's not as bright as the other fat around it. And on the T2, it's much more inhomogeneous in its signal characteristics. So you can see here, much of this is what it looked like when it was excised, and this was a dermoid cyst. And the dermoid cysts tend to have this kind of dirty appearance with inhomogeneity within them, and not as high signal intensity on the T1 weighted image. So this was a dermoid cyst. Pretty unusual location for this. You can see these in the pelvis and the typical characteristics of dermoid cysts. And then the other thing you always look for is if there is a tooth or something like that, a focal area of low signal intensity, combined with a tooth or a calcification within them, which you're all familiar with. 50-year-old female, right thigh mass growing for 7 to 8 years, rubbery hard and non-tender. We can see it on the plain film here, ultrasound characteristics, and then here's this mass in the subcutaneous tissues on the MR examination. And there it looks like it has a lot of fibrous bands in it, a lot of inhomogeneous signal, areas of probably fluid here, bright on the fat suppressed, and that was a xanthoma, the soft tissues. Here's a 40-year-old female, T1 coronal, inhomogeneous mass here on the very inhomogeneous enhancement pattern. Doesn't look like a lot of fat in it here, so I don't know why I have this on. Oh, that's why. So on the T1 weighted images, what you can see here is that there's actually very little obvious lipid in this particular lesion. There's a little inhomogeneous, and it may be a little bit brighter than the muscle around it. Much more inhomogeneous in signal intensity on the other sequences. So clearly on these other sequences, this looks more malignant with the inhomogeneous signal that we talked about other as typical of malignant disease. Certainly this enhancement pattern is something that you'd be very worried about. In the soft tissues, lipid tumors, liposarcomas, especially low-grade liposarcomas, are a very common tumor, but just remember that they often don't have obvious fat in them. But the high signal intensity here probably is fat that's within the tissue, but not enough to fill an entire voxel.
Dr. Cruz,
Yes.
Can you do like in and out of phase on these to demonstrate like intracellular lipid, or does that work for liposarcs that don't have like obvious macroscopic fat?
Let me think. That's yes. And I'm just trying to think for a minute. I believe I may have an example of that where that's where the ideal sequence, where we get the in-phase and out-of-phase images on the ideal sequence, actually show that characteristic. And actually, one of our former fellows here, who's out, David Dang, really first brought that up to me and showed me some examples of some low-grade liposarcomas out in the Pomona Valley that he evaluated within and out-of-phase imaging, and he found that actually to be very helpful. So I think that's a very good point. And another nice reason to use ideal imaging if you have it on your scanners. I believe I have some examples to show of that later. But a very good point. Here's a 47-year-old physician who had a large buttock mass, which you can see here. Suppresses with fat suppression. Again, it's a lot of inhomogeneous signal intensity, so this could not be put in the benign category. This is one that you'd have to be concerned about. Axial images still, it's mostly lipid, but there is other signal intensity in it, but certainly this doesn't look as bad as some of the other benign lesions that we talked about earlier. This was on 7/5/2001. This turned out to be biopsied and was a low-grade liposarcoma, which was then removed. And here's the postoperative findings. But even on the postoperative study, there is some lipid tissue in the area of concern. This actually started growing. They went back in and removed more tumor shortly after this MR examination. This is on 7/13/01. Then the patient was being followed, and notice there's still some lipid area in this area. This is on 7/13/01. If you look at those areas, 7/27/01, still inhomogeneous, but on the fat suppressed sequence, it's hard to see it. Now, this patient now was followed over a number of years, but the interesting thing at one of our local institutions here was followed, but whenever the patient came back, the imaging protocol was completely different. In fact, it turned out when I went back and had to review these, they had about 7 or 8 MRs, and there were no 2 dates where they had T1 weighted images in the same plane to compare with. And I just want to bring this up as something, when you get out into practice, there's something very important about having stable protocols that are the same when you bring people back. Because what happened here is that they didn't have the same sequences to compare when the patient came back. And here they came back, and actually there's much more lipid here, but they didn't have a corresponding film like this back in 2001. And this was not completely recognized as being potentially abnormal until this study, where we can see that there's a very large area of fat here that wasn't there before. But in the early stages, they couldn't pick this up because the T1 weighted images were all in different planes, so they didn't have apples to compare with apples. The story about this is that actually this wasn't actually picked up until 2007, where it was finally they got 2 axial images together from different time periods and realized that this fat mass here wasn't there before. It was there in 2004. You actually, in retrospect, you could see it back in 2003 as slowly growing, and this was a recurrence or persistence of the liposarcoma. The patient ended up having to have a hindquarter amputation because of this after several other surgeries. And obviously it ended up in a lawsuit. So fibrous lesions. They're typically low in signal intensity on all sequences, sometimes on the fat suppressed sequences because you suppress the signal from surrounding tissues. They can look more iso-intense. Typical example, they tend to, this is a typical pressure lesion which occurs overlying bony prominences, which due to recurrent trauma, especially common in the foot areas, especially at the fifth head of the 5th metatarsal is a common location. These can be very, very painful lesions if any of you have had them, but they can also be completely asymptomatic. So you can't really differentiate whether they're symptomatic or not on MRI. You can just describe them, and typically the best way to determine whether they're significant or not is if the marker is over the lesion, then it's probably significant. If the marker is somewhere else, it's probably not. But just be aware of these. These are scar tissue fibrous thickening, which can be innervated and be painful, and often called pressure lesions. Another fibrous type tumor in the soft tissues is this. This typically occurs along the plantar fascia. I think the vast majority of these are actually traumatic lesions with chronic repetitive trauma, where it tries to heal the plantar fascia, but they keep injuring it. So you end up with hypertrophic scar formation that can enlarge. Though some of these may be actually benign neoplasms. From what we know historically is that if you don't do a wide resection, these tend to come back, but it's unclear whether it's because it's a neoplasm or whether it's that you have the same process occurring which produce hypertrophic scar. And it may be both. There may be some true benign fibrous neoplasms which can present here, but considering the area, considering this typically occurs in the plantar fascia where you know there's trauma, where you know there's a lot of stress on it, my guess is that a lot of these lesions are probably due to hypertrophic scar formation from repetitive injury to the plantar fascia. But here we can see it again. The treatment typically for these is a wide area resection. as
Dr.
an example. Yes.
Quick question. It seems like a lot of those tend to be pretty bright on T2, which is kind of surprising because they're fibrous. Is there a particular reason that they're brighter than typical fibrous tissue?
Yeah, I think it's because they're scars. And as you know, when you have active scar formation, you have a lot of granulation tissue which has active cells which are trying to repair the tissue. So I think the reason why these tend to be brighter than others is that they're actually active granulation tissue and not just a chronic scar.
Okay.
Yeah. But it could also be, and some people believe that it's because you have a benign neoplasm and the neoplastic cells are brighter signal intensity. The bottom line is that they're kind of treated the same way. Of interest would be whether you could actually do a study where you would allow these to heal early on in their course, but I'm not aware of any studies that have looked at that. Typically, you just do a wide area resection. The patient underwent resection. Here we can see the area of the resection, and you can see that there's kind of a recurrent mass, and this actually recurred with a fibroma. And if your gudis were here, John, your gudis were here, he would say that you really have to have more than a centimeter margin around the entire lesion for you not to get recurrence. Now, fibromatosis, we'll see a lot of different examples of fibrous lesions called fibromatosis within the body. Certainly, there is a very aggressive form that's malignant, especially in the torso of the body. But there are a lot of localized areas, such as Dupuytren's contractures and other areas, where we will see fibrous lesions in certain anatomic locations, which are very characteristic, like plantar fibroma that we just saw. But we'll also see some actual malignant fibrous lesions in certain areas when we go through the different body areas. So there's a big differential of different kinds of fibrous lesions. Here's a middle-aged male with a history of trauma, now with a mass in the area of the trauma, and we can see what looks like a muscle tear, but a very inhomogeneous mass in this location. When you see this, it'd be nice to get a plain film, because they can often be diagnostic and very helpful. Here we can see the complex nature of this with the edema going into the muscle. This is a very characteristic appearance of this. So occasionally you can see a fluid level on the MR examination, because these are often associated with a hematoma in the area, and this is Myositis Ossificans. And typically, as you know, you tend to have more of a eggshell type calcification around these. 28-year-old female with a leg mass, and here we can see a large mass here, also with a lot of areas of low signal intensity within the lesion. Very long here. So again, it's the same characteristic of kind of fibrous or low signal type lesions. There's the PD fat cell or stir. This may be a stir lesion where we can see some high signal intensity within the lesion. This was actually an extra-abdominal desmoid tumor, and this happened to be a malignant tumor. And you have to think more in terms of malignant when you see the size. More than 5 centimeters, you've got to be concerned about that. 49-year-old female with a very hard soft tissue mass, which we can see a lot of low signal intensity within it. But we don't see any actual calcifications that are associated with those low signals. But it was a hard type mass. Here we can see the lesion here, low in signal on most pulse sequences with these dark, probably fibrous areas, and this was a desmoplastic fibroblastoma, another fibrous neoplasm in this particular case. A 37-year-old female, again a lesion that has a lot of low signal intensity, but also some high signal intensity areas within it. Oops. Sorry about that. Let's go on to this case. I must have accidentally removed the rest of that study. 40-year-old female, right foot pain. This was an early study where we can see this mass in the area of the foot, which is extending around, replacing a lot of those the normal muscles in this area. The initial impression was it was probably a schwannoma of the digital nerve, but it came back plantar fibromatosis on pathology. And these can be infiltrative type lesions like this. You like to see lower signal intensity within this, but if they have a lot of granulation tissue, even though histologically they're predominantly fibrous, they still have enough signal intensity where they can be bright on the signal. These lesions all tend to have relatively smooth margins around the lesion, sharp demarcation without much edema around the lesion. And then this patient had bilateral scapular pain, typical appearance of masses of elastic fibroma on both sides on an MR examination. And that has a very characteristic appearance and location, which is pretty pathognomonic. 20-year-old female with mass enlarging for 1 year. I think this is the thenar prominence here, but we can see a mass like this, very bright in signal, a little bit indistinct margins of the mass on these. But notice how feathery the margins are here. Typically, malignant lesions are very smudged out, and you don't see this kind of detail, this feather little detail in the soft tissues. This looks a little bit like what you might expect a lesion in the breast to be. Oops. Sorry about that. I guess it, but here we can see also the lesion with the spiculated margins. This turned out to be also a fibromatosis. And it's an individual, and a lot of those spiculations were due to retraction from the fibrous tissue when it matures. So at this point, why don't we stop here? And tomorrow we'll pick up from here, and we'll go through the other characteristic soft tissue lesions, and we'll get past the fibrous lesions fairly rapidly. So I'll see everyone tomorrow. Okay?
Thank you.
Thanks.
Thanks, Dr. Cruz.
Thanks.
Would that be Monday, sir?
Oh, I'm sorry. Yeah, Monday I think is better. Not tomorrow. Not on Saturday. Thank you.